Good afternoon and welcome to our November quality webinar where we have Cheryl Manchenton talking about the IPPS 2022 updates and the impacts on quality. Before we get started, I did want to go over a couple housekeeping items. If you do have any sound issues throughout the webinar, there is a audio section in your dashboard. If you click on that, you can check your computer audio. And if you are still having issues with the sound on your computer, you can dial in using the dial-in number and passcodes. We encourage you to ask questions. We anticipate a lot for this one. We will get to as many as we can after the webinar. And any of those that we don't get to, we will follow up after. Also, we will be sending an archive out after the webinar as well in the next couple weeks. So if you do want to go back and listen, we will be sending it to the email that you registered with. If you do want to follow along with the presentation today, it is in the handout section of your dashboard, so you can download the PowerPoint there. And again, within the archive, we will send that PowerPoint as well. And lastly, we would appreciate if you complete the survey at the end. We always appreciate your feedback for our speakers and presentation. And so I know we have a lot to get to, so I'm going to go ahead and pass it on over to Cheryl.
Thank you, Lisa, and good morning and afternoon, everyone. Obviously, I'm Cheryl Manchenton, inpatient consultant. I'm not going to spend a lot of time with my CV. We're going to get right into it. Our goal today is typically, for those who have joined us in years past, it is a duo presentation between myself and Audrey Howard. Unfortunately, she is not with us because she is on vacation this week in a nice, sunny, warm place. So she and I have reviewed the content, and unfortunately, like I said, you're missing Audrey and you just have me. But our goal is to talk about the significant changes that were brought forward in the 2022 final rule. We're not talking about the COVID one specifically. We have covered that in other avenues, but if there are people who still have questions on that, please make a suggestion. We're happy to include that in the quality webinar series next year. I do think there is, some concern, how is COVID data being used and not used? But our purpose really of this one is to talk about what new codes, coding guidelines, et cetera, or revisions, tabular and alphabetical revisions impact quality. And again, give you that information, okay? So going forward, this was a sneaky one. And actually, I was unaware of this until one of our physician leaders had brought this to my attention. It's not just enough to check your new CCs, MCCs, and tabular notes. We also have to see what is new, deleted, changed off of the POA exempt list. Most of the time, it's because they've expanded and created new Z codes, such as the homelessness codes, but there was actually a tricky one this year. The Z51-5 code, which is your encounter for palliative care, has been moved from the regular POA yes or no into the exempt list. Obviously, I think it kind of stands on its own, meaning what's the problem? Some of the risk-adjusted models for quality benchmarking, some of the big names that we're all familiar with, actually use that to risk adjust their patients when it was present on admission. So now this having a POA of exempt, uncertain what they're going to do or how they're going to use that or not include that. So we can't be dependent that this would or would not have provided a risk adjustment and or an exclusion for our patient. And again, what I'll say, when I say sneaky, in that this was not, it wasn't like publicized in any of the final rule comments or any of the webinars or thing I've seen. Sometimes some of this is just produced and we incidentally find out about it. Our next one is an indexing change, and on the surface, it's very clear why they did this. The instructional note underneath acidosis E87-2 has always been an excludes 1, but you'll notice they inadvertently or intentionally, whatever way, they did not include the E11, which is our regular type 2 diabetes, on that exclusion with acidosis. So they have either corrected an oversight or changed their philosophy. And again, we can kind of debate which way that is. Either way, it's now on the exclusion list, the excludes 1 list. So let's talk through acidosis and what that impact is. I know several of my clients are now getting in their coding sessions, they're getting the excludes one edits popping up saying, you know, you can't code acidosis in a patient with diabetes. If you quickly read that and say, okay, I can't code it, you know, we're really going to be underreporting possibly the number of patients with acidosis. And we know that it is a commonly utilized risk adjuster in most of the quality models. To mitigate that, please remember that an excludes one note is only if the conditions are related to each other. And if the acidosis is unrelated to diabetes, and when you think about a typical type 2 diabetic, they are unrelated. So if it is unrelated to diabetes, we can override that excludes one note and capture the acidosis. And of course, when you think about what else causes acidosis besides diabetic ketoacidosis, we know we have respiratory types, we have lactate types, we have metabolic types with a whole slew full of causes. A little bit more rare one is your renal tubular acidosis. And our recommendation to everyone is not just getting that the acidosis is due to fill in the blank, you know, meaning due to sepsis, but get the specific type documented, right? So not just saying, let's call it lactate. Let's make sure that we get a specific type and a good cause and effect so that our coding professionals can then override that excludes one note. But, you know, at surface, it's something you need to make sure at your facilities that the coders are aware about this new excludes, and then our CDI staff and our providers understand what our role is to ensure that when it is clinically appropriate to capture, that we are able to get the documentation to support its capture. Our next one is, again, a small change, and sometimes the little things have big impacts, and this is about bronchiectasis. And for as long as I can remember, which has been 13 years, bronchiectasis has always had in either I9 or I10 a code first note, essentially meaning there was a use additional code to identify the infection. So for example, a patient with bronchiectasis who had pneumonia, pneumonia could never be the principal. You'd also always have to report J47 as principal, and the pneumonia would be a secondary, was excluded as an MCC, and from a quality concern, that was probably a good thing for us. Financially, it was, well, probably not helpful, but bronchiectasis is not part of the COPD mortality, 30-day mortality or 30-day readmissions cohorts. Whether it's principal or secondary, it's not part of the group. You know, so it provided us some comfort when it was the principal diagnosis. So of course, then what happens when I'm not forced to use it as principal? That means pneumonia is of course now eligible to be sequenced as a principal diagnosis, and what the sometimes downstream effect of that is you have more patients who are now part of that pneumonia cohort for your mortality and your readmissions. Again, if you do have an exacerbation of your bronchiectasis that you can, you know, if we do know that it is exacerbated, you have a choice between the pneumonia and the bronchiectasis. But before we didn't have a choice, we had to code it as principal. Now we have a choice. And so for those that are having excessive mortalities or pneumonia readmissions, you know, be looking at how much this could be indeed affecting your outcomes and in your population, your index population. So again, subtle change can have a lot of downstream impact. Our next topic is depression. And really, I know most of us were very frustrated when we moved to I10 with the specificity allotted for depression. Unspecified depression was indexed to something that was clinically inappropriate, as in major depressive disorder single episode. That was not consistent with the clinical world, and honestly, we have been over-reporting something that is not nearly as common. So thankfully, the Coordination and Maintenance Committee did give us a new code, F32A, for depression unspecified, not otherwise specified, okay, and took it out from underneath the major depressive disorder code. So it's good for the integrity of the documentation. right? Unfortunately, it's not a CC or MCC, right? But let's kind of talk about that. What's the quality impact? It's actually a clinically correct decrease in the reporting of HCCs, because regular depression is not on the HCC list. So we might have been overstating the number of HCCs we had. The second thing is, I have heard stories, again, I can't confirm or deny the stories, but I've heard instances where consultants have said, query for major depressive disorder to get your CC. Ooh, we need to make sure that we double check ourselves and make sure that it is consistent with the clinical picture. What indicators are present to show that it's a major depressive disorder, significant lifestyle changes, weight loss, multiple admissions, medication adjustments, et cetera. Not just they have depression that is well controlled on a single agent and are not having any impact from that diagnosis. Second commentary on this is, it's truly not clear whether or not that will be expanded into any of the models, the risk adjustment models, whether it be, again, the quality benchmarking or CMS's list, because again, for the CMS mortality and readmissions groups and HCCs, they are using some older databases prior to the creation of this code, right? So it will take, I think, several years before we figure out whether or not how this code will or will not be utilized in risk adjustment. So like I said, I think on the one hand, some would say this is negative, and I think it is correcting the course as it probably should have been from the get-go. And at this time, we'd like to introduce our first polling question. So Lisa, if you could key that up for us. Thank you. And again, just kind of getting a little bit, just some curiosity. We have our new code for the acute myocardial injury that was just created this year. Of course, this has been a definition since not just the fourth universal definition of MIs, but since the third universal definition, global definition of MI, and we have not had codes for it. I know when the third definition came out, there were a few of my facilities that were really struggling because the doctors did want to use the language, and we did not have codes that would equate to what they were trying to represent. So my curiosity is now, with this fourth definition and now codes available, our question is, are you seeing this in your documentation? Are they documented when they should? Is it sometimes documented, rarely, never, or you're just not in tune with that data? And again, we just appreciate the insight. And Lisa, if you could share the results.
All right, so 21% said when clinically appropriate, 26% said sometimes, 27% rarely, 12% never, and 14% I don't know.
Great, thank you for that. And again, I appreciate those that did participate. I think, of course, what our goal is that we would have the vast majority of our organizations and providers being in the A category. I'm glad that we do have a fair percentage of patients in the sometimes. In other words, you are seeing that sometimes documented. I think part of this, as we go through these new codes and talk about it, part of this is really, it's a word, broad-based education, meaning your quality staff, your coding staff, your CDI staff, and your provider staff, that we do have these new codes available, and again, sharing with them the clinical definitions of the injury. And as a side note, I'm giving a shot ahead for those that do use our 360 Encompass software or any of our other products in which we do have a query library. We are updating and creating a new query that will account for this as well, to give some clinically relevant choices, including the acute myocardial injury. So just stay tuned. That it's a couple months out, to get that released in the software. But we are also aware of our need to assist organizations, not just with the education, but how to get those questions answered. So again, as I've kind of explained in advance, we have this new code, the I5A. Some things to note about it, that you have those words in parentheses, meaning those are non-essential modifiers. They're also included or indexed to the I5A code. So they can either use the term acute myocardial injury or non-ischemic myocardial injury or acute non-ischemic myocardial injury. And you'll also notice there is a chronic and an unspecified, all assigned to the same code. You'll also note it is a CC. We have instructional notes to code first which caused it. So similar to our type 2 MIs, this code cannot be a principal diagnosis. And again, it's not a comprehensive list of things that cause the acute myocardial injury. They're just giving you such as, okay? And of course, we have our normal excludes one, that if it's actually an acute MI or it is an injury of the heart, meaning a traumatic injury or other acute ischemic diseases, we'd assign those codes, again, depending on the circumstances of admission, et cetera. So with this, again, new code creation, again, I want to talk a little bit about and reshare a couple of things. I know many of us have been to a bunch of different seminars where we have seen these definitions. I really kind of like this because it makes it very simple. Really, your patients who have a non-traumatic rise in troponin kind of fall into one of three categories: a type 1 primary coronary event, a type 2 coronary events caused by supply-demand mismatch, and then all the other causes of elevation in troponin, excuse me, in the absence of, again, ischemic events, which would be type 2s or 1s, or trauma. So again, this is their global task force definitions. I also really liked, this came from their original publication, how they really wanted to help us think through this. And I think, again, I say to my listener friends here, I think sometimes the chart helped me think through, what is this? How is this distinctive? How do I think about this clinically? The chart helped me think about what diagnosis is best representing what I'm seeing there. So again, just a couple of, the image just kind of helps me kind of sort through it. But of course, today's session is, how is this impacting quality? First of all, it is, and again, you could call it a negative impact. My physician colleague and I decided we like the word accuracy, similar to the depression. You are going to get less inappropriate non-STEMIs reported, right? So that is a good thing, but that does lower risk adjustment. We know that. Second thing is, I do think that we'll have to do less clinical validation when the circumstances and the rise in troponins, et cetera, is not really an ischemic event. We're not going to have to do as much validation when the providers start using this language. From a positive, because there is positive to this, you will have less MIs reported via your non-STEMI code, of course, as your principal diagnosis, and that will result in less MIs qualifying for the CMS readmissions or mortality cohorts. Again, the type 2s were never used, and just one other thing to consider with getting the accurate representation. I think the providers were using whatever we asked them to document to get to a code, such as demand ischemia, or we had providers saying troponin leak, and we did not have a way to represent that. Troponin leak could be either chronic with our renal failure patients, or it could be acute, due to, again, a stressor on that heart. And instead of trying to force them into codes that might not have been clinically correct, or that there is really no good established definition for, we now have this other category. And again, some people will say, we're losing a bunch of MCCs. And Dr. Wolf and I would say, no, we're getting the appropriate clinical representation of our patients. So this is kind of a mixed impact on quality, shall you say. Next one I want to highlight is irritant contact dermatitis. There was a whole, I think where I start here. Our Wound Care Association professionals have long asked the ICD-10 and Coordination Committee to expand the use of skin condition codes that were available to us. So many of us can remember before, DTI was actually a code and it was assigned to unstageable, but that is a completely different clinical entity than an unstageable ulcer with a bunch of eschar, right? So after much request, or numerous requests, the Coordination and Maintenance Committee did proceed with those DTI codes a few years ago. There are additional codes that the Wound Care Association, or skin classifications that they use, that have not yet been adopted into codes. One of those being healed pressure ulcers, because if it's a stage 3 or 4 and it's healed, you don't actually grow back all your dermal layers. You have a bunch of scar tissue, and it's a very different clinical entity. And the other one that we don't have yet is the device-related pressure ulcers, due to an ED tube, due to a BiPAP mask in our COVID patients, due to a Foley catheter, things like that. But on a positive note, they did expand the codes available for the irritant contact dermatitis. And I'm going to give them a shout out because they didn't just give us a code, they gave us a bunch of codes. Now, none of these are CCs or MCCs, but they gave us a lot of specificity as to what was the irritant causing that skin breakdown, such as a body fluid unspecified, or saliva, or of course, probably most commonly for a lot of our patients, the fecal urinary or dual incontinence. You do see some excludes note. And again, or other fluids. It could be, something due to such as the endotracheal tube, or wound fluids exudate. Going onward onto our next slide, this is where I really think they got even more sophisticated, is they included those that are device-related irritant dermatitis, such as that surrounding a stoma or fistula by type. And again, I really, really appreciated the code expansion. Okay, so we have these new codes. Why is this such a big deal? Well, again, I think overall, as we have appropriate codes to represent our patients, we will hopefully have less pressure ulcers documented. Again, I think sometimes we are trying so hard to fit the clinical picture into the available codes. And, by that meaning, some of these, of course, end up, diaper dermatitis ends up typically in a dependent position, right, in the areas of pressure. So, of course, our task is really to make sure that, one, wound care knows, hey, good news, we now have your codes, your classifications are now available. And again, that we're appropriately coding. And again, we could have an evolution to a non-pressure ulcer in that same location. They get a little dermatitis, they get some skin breakdown, and it then degrades into an ulcer. The only other thing that I will caution everyone, though, is the way the wound care nurses typically describe them are moisture-associated skin dermatitis, MASD, or damage, moisture-associated skin damage. MASD is not indexed to these codes, so we're going to have to take the wound care nurse's language and then offer compliant choices to our doctors to use the contact dermatitis, and then again look for additional documentation of the degradation into a non-pressure ulcer. And again, obviously, this is obvious. The less pressure ulcers we report, the less PSIs and HACs we have, because most of these are not present on admission. But we also know pressure ulcers are great risk adjusters as well. So it's kind of that mixed bag of wolf message there. And as I said earlier, the other types of codes that the Wound Care Association uses, we still do not have codes for those yet. So, I think we've made progress. We're just not completely there yet. The next one, I think this is nothing but positive. They created an expansion at this S06A code category range because the category or the code used to just include traumatic brain compression and herniation. And they have now expanded that to include compression with herniation or without herniation. And again, you can see the additional specificity or terms that are assigned to each of the codes. You also see an instructional note under the general category that these are not your principles. You code first that which caused it by its type, whether it be a diffuse traumatic brain injury or focal or your subarachnoids and subdurals. They additionally provide us some instructional notes, again, as I said, at each category. They made sure that not just for the SO6A code, they actually put it at these codes to use the additional code for that traumatic brain compression and herniation. So they gave us 2 reminders that if we do have compression and herniation, we are able to capture those as additional diagnoses. So what is our impact here? And I chose this visual because I think it's a great reminder of overlap, right? Conditions such as compression and herniation are not integral to every traumatic brain injury. And secondly, not every patient with compression actually develops herniation. And again, for those who have ever taken care of neurologic or neurosurgical patients, of which I did, there is a distinct clinical difference between the two. And especially when you watch, unfortunately, a donor herniate, you can see how that patient changes, how their presentation and how they become extremely unstable. So to have that differentiation is really good for several reasons. One, it's really good for our trauma registries and our neurosurgeons to really look at long-term outcomes when they do have associated diagnoses. Again, these can be specifically utilized in risk adjustment, right? Not just a general compression, but compression versus herniation. You know, should there have a different level or effect on risk adjustment with that further specificity? And of course, with 3M, again, this is something I need to do a little homework on to see how these new codes are assigned in our APR definitions manual. But, you know, do know I think that this is nothing but positive to provide more detail, again, as long as these are significant compressions and or herniations that are happy to, you know, that we're able to further reflect. This one is really near and dear to my heart, and I have done a lot of education with my own clients, and I just want to reiterate how pleased I am by these. They did add some new social determinants of health, the Z55.5, the Z58.6, and then they did a code expansion on the homelessness, and then they added codes for food insecurity versus other specified lack of adequate food. Of course, like other social determinants of health, these are not CCs. But again, I think we all realize the importance of these and why they're helping us from a quality perspective. Again, adding on the new codes for the Z5981, the housing instability. And I think what I really sometimes like is the detail they give us in that code level. In other words, I can read not just the title of this code, but I can see the inclusion terms to help me determine the appropriate code. So really nice. This was sponsored by the Gravitas Project, which is really trying to expand our definitions for use of and how we apply this to actually help patients who do have social determinants of health. In addition to creating the new codes, the official coding guidelines were updated. They have been, over the past several years, we've seen some revisions to the coding guidelines, and they were tucked into some other general guidelines about what we can code from non-practitioners. But with the increasing importance of them, they have now been called out on their own specific category. So there's your own specific section of the coding guidelines. And again, it has the same information. We can code them from medical record documentation from clinicians who are not the patient's provider. So that means social workers. And they gave us examples. Social workers, community health workers, case managers, if it's in this official record. And again, they repeated the advice that we can take the patient's self-reported information or the family saying, she's been sleeping in her car for 6 months. You know, we can take that information. We don't have to verify that patient is telling us the truth. We can code that information. They, of course, included the entire code range as well. But they did say they're located primarily. So it's not an all-inclusive list, but they did show us especially that code range of where the social determinants of health are that we're able to capture. I do, again, kind of like why they created them. In other words, this is some information why they created the education of less than a high school degree. There are some codes for literacy and underachievement. They did not differentiate those patients that did not have a high school degree, despite them being having a literacy issue or not. And of course, again, there is a huge, I don't know if the word clinical social difference, there's a huge difference between a patient who actually has a shelter and a place to stay versus one who's unsheltered on the street. And where this really came into play this last year, especially in one of my clients, is they actually had to have, I don't know what I want to call them, a transition house for their COVID patients to recuperate in, and because they weren't sick enough to be in the hospital, but they weren't well enough to go back to being homeless. So they had to have a respite care place for some of these individuals. And I think it was really helpful to be able to see how many of those patients and be planning for, what should our volume be? And obviously, being housing unstable, especially I know with all the changes in the rent, the eviction moratoriums and things like that, being able to note that you're unstable or behind in mortgages, you're making choices, right? Often patients are making choices between paying their rent or their mortgage and getting their medications filled. And certainly food insecurity, if you don't have access to good, healthy food, that it's hard to stay healthy. And you would think, and I apologize, sometimes I am every once in a while shocked about patients who don't have adequate running water in their facilities. And I saw a chart just a few months ago like that, and I was extremely saddened. And it wasn't necessarily, again, a patient out, homesteading somewhere out in a rural community. I mean, this was a patient whose current living environment did not have good, clean water. And so, she was constantly dehydrated, not taking her meds, and having all sorts of other problems from that as well. What is the impact of this? First and foremost, if some of you will recall in the CMS proposed rules, they actually asked for public comment on how to report health disparities. And they asked for our comments on whether or not social risk factors and race and ethnicity should be reported. And you'll notice, again, they gave us, and this is actually kind of a quote from them, about things that they were saying, should we be using this information? And of course, again, they didn't say they're doing anything. They said, we want to explore this and we're asking for public comment. It's really logical that at some point they will be incorporating that into risk adjustment in some way. I think it's a logical progression. And of course, because of that, I think the problem is if you're studying it now and you don't have a good code set, if we're not reporting this, we're not helping ourselves, and we're really ultimately not helping our patients. And again, you can tell I'm pretty passionate about this one, but we need to support the use of the codes, to be either supporting them either for payment or for risk adjustment or for exclusions, whatever it might be. But if we continue to underreport them, then we get what we deserve. And also note that this initiative is not just been going on at a federal level. It has been actually going on at the state level for several years. I know in particular, South Carolina being one place that has a project. And I don't think that I am so psychic as much as realistic that we're going to continue to see a broad expansion of these codes. I do think this is not the beginning. I think this is the tip of the iceberg. And I will say again, the piece to this, the capture of these codes, it's a triangular piece. One, the providers need to realize they can and should incorporate that into their documentation, right? We need to share that with our non-provider professionals, our social workers, our case managers, those other people documenting the record. They've typically always done it, right? But we want them to be as detailed as possible and let them know, hey, we actually can utilize that. So there's an education out there. There is also, again, that triangular need to educate our coding professionals that these are not diagnoses. These are social determinants of health. These are Z codes. These are statuses that provide information about the patient. The codes don't magically walk based on a sentence in the chart. In other words, you have to look at the sentence, look through the available codes and say, what social determinant of health code should I assign to this patient? Is there one that is applicable? Everybody's pretty good with the non-compliance. We've had that around for years, but I think this is going to be a reminder to our coding professionals that you are allowed to read the sentence and interpret what code is assigned. And that is not always within everyone's comfort zone, but I think is really, really important. Our next category is, again, sort of updates to the coding guidelines. We did have a coding clinic that came out this year, and typically when something comes out like that, it's not surprising to see that they update the guidelines to match the advice that was published in Coding Clinic. So the coding guidelines noted that, for unstageable ulcers, and it used to be this way in I9, meaning we had a coding clinic in I9. It was republished, obviously, when we got to I10, but it was not in the official guidelines. And of course, some of us like to see it in the guidelines as well. So they reminded us that, if your patient is coming in with an unstageable ulcer, with a chunk of eschar, and we debride it during this day, whatever depth that we find during that debridement, or as it gets deroofed enzymatically, right? Whatever that depth is what we assign instead. And again, you would assign the appropriate POA based on, was that unstageable ulcer present on admission, yes or no? So we'll say the patient came in with a unstageable ulcer of the left heel present on admission. And during this day, even though it's a week or two later, we do an excisional debridement and we can see that it is a stage 3. We would not code the unstageable, we'd assign the stage 3 with a POA of Y, right? So again, lots and lots of education to our professionals to make sure that they are understanding the official guideline and making sure that our wound care specialists and our providers understand why we're sometimes, questioning POAs or again, not having to question them or why we're assigning it this way, because we're following the guidelines. Obviously, the quality impact, not only was it added to our guidelines, again, they additionally published a similar question regarding the evolving DTI. So to me, that means, yes, next year we're going to see a sentence in the DTI guidelines about a DTI that devolves during the stay with similar advice. I think I was kind of disappointed they didn't update the DTI guidelines, but I think that they will. Obviously, the quality impact is when you're properly assigning not only the type of ulcer, but also its present on admission status, is going to reduce our number of hacks and PSIs. And again, that's what's clinically appropriate. We're not trying to avoid getting dinged for something we caused to the patient. We're just making sure that we're best representing what was present when this patient came in the door that we may not have been able to see the depth. So I think this is a win-win for data accuracy and for obviously quality. Few other really subtle things. Last year, I had a client that I've worked with for a long time, and as our use of the Glasgow Coma Scale, when we were and weren't allowed to change them, has evolved over the last few years, last year they kind of made a boo-boo, and I say that meaning they used to take the whole R40.2 category and say, the entire coma scale code range could only be used with traumatic brain injuries. Well, we know coma is not part of the GCS scale. It is a condition outside of it. It happens to be in the code range. So they unfortunately included it. And so I had some clients who were not coding coma in non-traumatic brain injuries, and we were underrepresenting coma. What they did is change the guideline from coma scale to coma. And again, in green, you can see they added a sentence that unspecified coma may be assigned in conjunction with codes for any medical condition. And of course, reported, kind of updated the second sentence that we would not report them for unspecified coma or any GCS score for a patient that was medically placed into a coma or sedated. And again, then updated the specific code range to be only those for the traumatic brain injuries. They limited it to just, again, the GCS code range. So they did not only correct the little oversight, but they doubled down on it and making sure that it was written in the guidelines clearly for everyone. The only other addition is at the bottom, and there was a recent coding clinic on this again, and they sometimes again publish it sort of in advance of updating the guidelines. What do I do for a patient that has 3 different levels of consciousness within the first 24 hours? Which one do I report? And of course, they said you would only code that one for the score at the time of admission. And obviously then we have a code available for when it's greater than 24 hours, but again, they felt that they wanted to make sure everybody understood you have to take what you got at the time of your inpatient order, and then you can of course take those ones prior, per the EMS or the time of ED admit, and then the one beyond 24 hours. But again, they specifically added this particular guideline to make sure that we weren't picking something that happened within 24 hours and using that. Quality impact is pretty obvious. Again, due to the oversight in that code range, I do believe that there were some facilities, I know some facilities were underreporting. I'm not saying that was global, but even one hospital's data not reporting this is just unfortunate. So, we can report the coma in your non-traumatic cases, and we understand and appreciate how important the diagnosis of coma is in terms of risk adjustment in pretty much any model. We know that it does not portend well for the patient nor their survivability. So again, this small change is making sure that everybody is able to code coma when it is clinically appropriate. Next one, and this is a subtle one, and I think not everybody noticed this one. And I know, again, as Dr. Wolf and I were reviewing this, it's like this one, it has a good sneaky effect. So, you basically have 2 sort of Impella devices, and what they did is not Impellas, ventricular assist devices. You have your quote unquote, air quote, permanent ones, meaning they're meant for long-term use, and Impellas that are used during the short-term setting, either to get me through surgery or to sort of wait. And what they did is take those out of 1 DRG into the 216 to 220. And depending on what it was, again, there were times that what we were putting in, we might have been assigning it into the bad range. And of course, we want to make sure that we have these categorized into the right MSDRGs, because when they're inserted for things such as acute MIs or, with cardiogenic shock, for PSI4, those patients will be excluded. And as a reminder, HRQ is using previous logic, so it'll take a year or so before they will catch up with us. And with that, those are my highlights. And Lisa, I think we can turn it over to questions.
Yeah, absolutely. And thank you, Cheryl. There's so much information. So I'm sure there's going to probably be some follow-up questions. So we just have a couple from Brandy. Speaking of major depression controlled, could not major depression in remission be more appropriate if the patient is doing well currently?
That's a great question. I think the problem clinically with depression is there's so many varietals by that. And by that, I mean, there's depression, mixed anxiety depression, MAD, I believe they call it. There are major depressions. The patients can be in remission. The problem is you have situational depression, right? Meaning that it's an acute event triggers something bad, and over time, you do pull out of that. But I think there is a strong group of patients with depression that have it as a chronic condition that never really goes away, but is just necessarily controlled. I think in remission I think mental disorders are a little bit different than substance abuses, in that I am not currently using, so I don't have, I'm not actively using. So it was dependence and remission to note the fact that, I am no longer ingesting substance, but, of course, we know those patients are considered, in theory, addicts for life. So I don't know that in remission is necessarily something that would make sense. I think at this point, again, for most people, that take antidepressants or fight depression, I think it never makes it really go away as much as it just lessens the effect. There's always a degree, just maybe less pronounced in some people.
All right, and the next question that we have is, what is the WD nurse stage inconclusive? Or I'm sorry, I think it should say, why
Yeah.
is it saying that it's inconclusive, and will it consider as unstageable or unspecified?
Okay, so the question, I think, I'll try and paraphrase because it's a good question. So my wound care nurse says the stage is inconclusive. What code do we assign for that depth? You do not, I would not use unstageable, because unstageable is a clinical description that they have said, meaning they can't see the depth. I'm not certain what the depth is. To me, this is like unspecified type of neoplasm versus an unknown. We have two different distinctions. So I treat this the same way. I would be coding that to the unspecified depth, but again, I would be hopefully having some conversation with my wound care professional to see if we could get their best guess and say, okay, but what is your best decision on that, whether it be a type or a depth?
We have a couple of questions about the coma scale. Are you able to go back to that one a little bit and maybe paraphrase? It says, are the coma scale codes only for trauma registries? And another question is, can you repeat what you said about that? So if you could maybe just paraphrase that one again.
Sure. So the GCS codes, okay, the GCS coma scale codes are only to be used with traumatic brain injuries. But the term coma, a patient who is comatose or in a coma, the G4020 can be used in any setting, meaning it can be used for our medical patients, but our GCS scores are only allowed to be captured in patients with traumatic brain injuries. And I forgot the second half of your question. I was focusing on the first half.
I think it was just more about making sure they understood and paraphrase. So I think we got that one with the trauma registries.
Yep.
Okay. All right. Can you talk about the difference between myocardial injury and type 2 MI?
Surely. And again, I think for the purposes of this, we can get back to that. So excusing the quick eyeballs for those going, oh my goodness. Let me get back to that because I think I would like to use this slide as it catches up to you all. Again, I am not a clinical expert in this. I am telling you how I understand it. When you think about a rise in troponin, right? It can be due to, again, blunt force trauma. Troponin is released by the heart in duress, shall we say, right? And the way you think about the troponin is either I got hit in the chest by a football helmet, so that's an injury, right? Okay, that is a traumatic injury. So we're taking them off the table, or I've had, yeah, I'm gonna leave that one right there. Or I have an elevation in troponins because of damage to the heart that is non-ischemic in nature. And by that, I mean defibrillation, right? When you shock the patient, that is going to cause and I think of the myocardial injury on the right, the I5As, to be like a bruise. My heart is a little cranky. It's going to recover. It shows you it's not happy, but there are no ischemic changes. But when you think about ischemic myocardial injury, those two on the left in the pink and the black, again, the damage to the heart is due to a lack of oxygen, either from a supply-demand mismatch, meaning type 2 MI, or due to a primary coronary event due to a thrombus, plaque, etc., in a coronary artery being a type 1. These are saying it's not that the heart is damaged due to a lack of oxygen, it's due to something else causing undue stress on the heart. It's not an ischemic event. And typically with the two, especially the one on the far right, the type 1, very often they can actually develop what we'll call infarction, right? So in other words, dead tissue, right? They've had some damaged tissue in the type 1s and 2s. You know, typically it could, if we catch it early enough, it could be self-limiting, that it's not causing a lot of extensive injury, damage or necrosis. But for our non-ischemic ones, again, they don't tend to have dead muscle. They just have slightly injured, either chronically or acutely injured heart tissue. And again, not due to ischemias. And there is a whole, the word I'm looking for, there's a list of things you look for to determine is it an ischemic versus non-ischemic injury. You're looking for significant EKG changes, wall motion abnormalities, things like that. You know, new bundle branch blocks, things like that would be more indicative of an ischemic event, where for those on the right, the acute ones, you have an abrupt rise and decrease in your troponin without evidence of any ischemia. And the chronic is you have this chronically elevated, you know, it's not a normal level, it's just enough to be annoying when we're drawing labs. And again, I hope that makes a good differentiation for people, because so this is, you know, I am a cardiac nurse and I get the difference, but it's not my total skill set, but I do like to think of the difference. And I think the difference is what is demand ischemia? Dr. Wolf will tell you, if she were here, she said there is no universal definition for that. You know, we should not have been offering that choice. We offered that choice because some doctors were saying it, or because we're trying to find an equivalent code. But for this patients who have not had an elevation of the troponins due to an ischemic event, demand ischemia was not appropriate. For these patients who have an acute abrupt rise and then decrease, or a chronic increase in their troponins.
I'm going to add a question that just came in because it's relevant to this slide. So I'm going to stay here for a second before we go back to some of the other questions. Would the elevation in troponins in COVID patients be considered to be a myocardial injury?
Oh, thank you so much for adding that one on. I've had a couple questions around this new code, and this is the second one. I'm like, oh, well, that's a good question. Again, the question, I don't have an answer. And the reason why is really our scientists are going to need to tell us when they, and sorry, forgive me for being gross, but when they are actually going to study these hearts, taking heart tissue, doing autopsies on them. And I apologize because I'm not trying to sound crass, but you know, are they seeing ischemic damages inside the coronary microvasculature? You know, like with our COVID lungs, we've seen they're full of tiny microthrombus. Is that what they're seeing in our cardiac patients, right? Okay, if so, that would be more of those type 2 MIs, you know, but if they're not seeing extensive thrombus, I just don't know how I would classify them. I defer to my cardiologists, and the answer is you may not get an answer from them, because I think the science is still evolving. I think it's a great question, but wow, I don't know that we're going to know for quite a while yet. And I think for some of us, we're not going to see that. We're not going to be able to study some of these patients till they start getting some long-term cardiomyopathy, and we really start looking at them more invasively, because I do think we're going to have a rise in viral cardiomyopathy.
All right, next question is the Z51.5 still allowed as PDX now that the POA status has been changed to E?
Great question. So our Encounter for Palliative Care code, again, I want to make sure that we're all on the same page. The Z51.5 Encounter for Palliative Care was changed to an exempt code. It has always been allowed as a principal diagnosis in those appropriate settings. So I don't think making it exempt changes whether or not it can be utilized. It was not on the do not use as a principal diagnosis list, right? You know, CMS has these conditions such as type 2 MI are on the do not use as principal diagnosis. So it's not on that list. Believe me, I know I would have heard about that one, and I don't think there's any way that they could prohibit it from being so. I think again, I wish I knew the reason that they made it exempt, and I think it's a great question for somebody smarter than me to sort of investigate and find out.
All right, and I think we We have time for one more question because I think this one um, you might need to restate it a little bit, but could you please restate the triangular theory of capture for social determinants of health again?
I'm not totally certain of the question. I'm going to do my best. I think the question is, with a patient of social determinants of health, where can we capture it from? We can capture it from any setting. And again, I'll kind of try and slip forward to that slide. We can capture it from I think it was the triangle in particular somebody was asking me about. So let me get to that slide. No, I don't have a triangle for this one. I think we need to educate our providers that they should include it in their documentation. I think we need to remind our social workers and case managers that they can and be as specific as possible, since we get it a lot from them. We need to educate our coders, right? And make sure that our coders understand how they can capture these. So I think we need to attack this from multiple angles, is making sure that we are getting it reported by our coding professionals and understanding that they have some liberty to read the sentence and figure out which code is assigned. So I think we need to work with our providers, right? Our social work case managers, and then our coders, and of course our CDIs, as much as you can assist in those efforts by also, deciding what you believe the appropriate code is and then having those conversations. So I do think it is triangular, but I would not discount CDI being helpful in this. And again, collaborating, because I know sometimes, again, I just look through the codes, and Audrey and I will sometimes have a conversation and say, golly, what code would you assign for this? Here's my sentence. What code do we think fits? And remember, we're given that liberalness because they're not diagnoses. And I hope that was the question that was being asked. Again, I apologize.
It was. Amy did respond back saying that was it, and thank you. I am going to ask you now to jump down to the educational boot camps if you want to talk about those before we wrap up today.
Absolutely. So as you know, we do offer two different types of education boot camps. Our virtual advanced CDI training, you can see the first upcoming week is January 24th through 28th. And the project leader for that is Cheryl Manchenton. So if you like to hear me talk, or if you want to avoid me, don't attend. We do this quarterly, and I am signed up to be one of the main presenters for that particular week. And we look forward, you just have to contact your sales representative and we can have your staff members attend. We also have advanced quality training that is available. We have not yet scheduled the weeks yet for 2022. And again, we welcome anyone interested. It is a week of intense training specific to, a lot of the stuff we cover here is like, yep, those are pulled into my content saying, okay, here's something that happened in the coding. How does this affect this particular metric? So it's a lot more of this in great detail. And sometimes we spend a lot of time on the clinical things to talk about the quality impact. And again, you can see at the bottom the link where you can learn more about how to get more information.
Great. And what I am going to do is I am going to go ahead and launch one final poll that if you are interested in getting more information sent to you about this webinar, please select your top interest here. As we close out today as well, I do want to remind you that we are going to be sending out an archive of the recording as well as the PowerPoint, so you can go back and re-listen. We did have a couple questions. We don't actually provide the CEUs, but you will get a certificate of attendance. So you can submit this after to receive CEUs. And lastly, again, we really would appreciate you to complete the survey that will launch after the close of this webinar. And finally, I can't believe it's already November. This is actually the last quality webinar for this year. And so as we finalize our planning for 2022, be on the lookout so you can start to register for next year to join us again. And also, if you are interested in learning more about CDI with our CDI Innovation webinars, you can also opt into those to see what's going on with those webinars as well. And so again, Cheryl, we cannot thank you enough for your time today. You're always one of our most highly rated speakers, just with your background and knowledge. We certainly appreciate it. And so again, thank you all, and we look forward to seeing you next year.
Happy holidays, everyone.
Take care.